Thomas Baldrick here at the 2015 ASCO conference. Always a pleasure to have back with us Dr. Jonathan Gerber from the Levine Cancer Center in Charlotte, North Carolina. Thank you, sir, for stopping by.
Sure, thank you for having me.
So you've got some interesting work in the area of emerging evidence supporting the clinical significance of leukemia stem cells. What's just an introductory statement you could make about this?
Sure. It turns out that although we get most patients into complete remission with our therapies, very few of those patients are ultimately cured. And it turns out that we're really not targeting the cells at the root of the disease. These leukemia stem cells both give rise to the disease, they propagate the disease, and ultimately they're more resistant to the therapies. And so, although they're rare, and when someone receives treatment, if you wipe out the rest of the disease and the leukemia stem cells are all that's left behind, it looks like you've cured them, it looks like they're in complete remission, nothing's detectable, but ultimately those cells are still there and they regrow the disease from scratch.
So let's talk about the study that you've been a part of. What methods and what are some of the key findings you've gotten from those methods?
Sure. The hallmark of our work is really using a flow cytometry-based assay to detect these leukemia stem cells in patients. The report that we just announced was work building on actually projects from about 4 or 5 years ago, where we first identified these leukemia stem cells, found that we could separate them from their normal counterparts, and found that we could track those with therapy to see whether people were cured or not cured. This work actually built on some exceptions to the rule that we found during that project, where not all patients had the exact same pattern of their leukemia stem cells. Some marked a little bit differently than sort of the most common finding. And what we found were that really there's 3 distinct types of leukemia stem cells. Any given patient only has one of those. But it turned out that with this work, we were able to show that the type of leukemia stem cell that they have really seems to correlate pretty strongly with how they ultimately do. That one of them had a little bit more favorable outcomes, one of them, which is the most common that we had reported on before, is kind of middle of the road, and one of them actually absolutely dismal outcomes. And so we were able to actually determine that at diagnosis, really within hours of diagnosis of a patient, you could determine this, that these patients are not going to respond well to standard chemotherapy. None of them were cured unless they had an allogeneic bone marrow transplant.
That's a key fork in the road you discovered.
Yeah, I think now it allows us, this is an explosive disease that we need to really start treatment within hours to a day or two. And it really enables us now to out of the gates identify those patients that are going to do poorly, instead of starting treatment and finding out a week or two later, maybe it wasn't the best idea.
So is that part of the reason why you've had such a team approach to this study? You're not just a principal investigator, you're one of a large team. Can you talk about that, why you had this approach?
Sure, I think in this day of more and more specialized treatments, techniques, diseases, that it really does take a lot of cooks in the kitchen to get things done. And so we had a very industrious laboratory team of technicians and the like that are actually doing most of the hands-on work. We had experts in terms of statisticians. We had our clinical investigator team actually enrolling the patients. Many of us were helping take care of those patients. And we also had a team helping to do the analysis and the cell sorting and the like. So it really does take a lot of people to do this. It doesn't sound like a lot. We looked at 98 different patient samples, but an enormous amount of work to do that.
So what are the next steps you have planned?
We're actually going to continue to hone down, so we want to better define each one of these types of leukemia stem cells. We really want to begin to look at targets on these cells. It turns out that the targets that are readily accessible to us, so if you just take a sample of a patient's bone marrow or their blood that have leukemia, you're really looking at the cells that we actually have some success in killing, the slightly more mature cells. And by actually honing down on these leukemia stem cells, you find that targets that are present on their offspring aren't necessarily present on these stem cells, and vice versa. So really we've sort of been missing the target in many cases. We really want to look at these cells, examine them in connection with their normal counterparts, and now we can pull the leukemia stem cells and the normal blood stem cells from the same person at the same time point. So it really gives us a perfect control to start to compare and contrast for targets.
Very good. Thank you, Dr. Gerber. We wish you well.
Thank you.
Appreciate it.